Okay, so we have so good. We got a question for Dr. Phillips. It's kind of a tough one, but how successful are bone marrow transplants for lymphoma, and how can I increase my chances of success?
So, most of the time we do transplants as in large cell lymphoma, and a lot of that has really nothing, unfortunately, to do with the patient, but more so the disease biology. Auto transplants, historically, we've used for relapsed refractory disease. Unfortunately, for patients with primary refractory disease, auto transplants aren't very effective. I think we have several studies that looked at outcomes, Scholar One, and more recently, the CAR T versus auto transplants of the indicated that axi-cell and lyso-cell are better treatments. These CAR T treatments are better than auto transplant in this patient population. So auto transplants seem to now be best reserved for patients who we consider to have relapse disease, meaning you get initial treatment. Generally with R-CHOP, your cancer stays in remission for at least a year, and then we salvage you for another form of chemotherapy, and then you will get an auto transplant. The auto transplant obviously really just being high-dose chemotherapy with stem cell rescue. So basically, they use your own blood cells to rescue your body from chemotherapy. So inherently, your cancer still needs to be sensitive to chemo to be effective. Follicular lymphoma, we have used auto transplant very rarely. Ideally, in the quote-unquote POT24 patient population, it increased sort of the highlight of the benefits of an auto transplant, but I think we're finding that POT24 is probably a misnomer, as the majority of these patients have transformed diffuse large B-cell lymphoma. And so I don't think any of us really know what a POT24 follicular lymphoma patient really looks like and whether an auto transplant is really beneficial in that patient population. Mantle cell lymphoma auto transplants are probably on the chopping block. We probably will stop doing less and less of that because of more and more clinical data. There are some trials that are still ongoing that are looking at the benefit of auto transplant, especially in the context of minimal residual disease. We'll see how that reads out. And the other ones, we really don't do auto transplants at all. Allo transplants in lymphoma are a bit more difficult. They are probably only curative intent in several of the indolent lymphomas, so follicular, CLL, MCL, Waldenstrom's, marginal zone. Allo transplant are probably the only curative intent for most of the patients, but they do come with complications, and our patients typically either don't have sibling matches or are not young enough for an allo transplant, so they are seldomly used. Also, your cancer probably needs to be in a complete remission or a very, very good partial remission, still in from myeloma, to actually go to an allo transplant, which, is not always the case that happens. So for the most part, if you want to do things to improve your outcomes to transplant, if your disease is amendable, really just your fitness level is important, because there are a lot of things that will exclude you from being a transplant patient, whether it be age, lung function, cardiac function, et cetera. Those are the sort of controllable things that you have, is just to make sure that, A, you don't smoke, you try to stay healthy and active, and you eat a well-balanced diet. Other than that, a lot of the other concepts are really out of your control, unfortunately.
Yeah, again, it's really, unfortunately, it's your disease that was not your fault and nothing you can do. And transplant in aggressive like DLBCL, diffuse large B-cell lymphoma, in those late relapses, so meaning they get their chemo up front and the cancer stays away for a few years, let's say, and then comes back. Auto transplant can still be quite a useful treatment modality that can result in cure. But for those early, or the lymphomas that never really go into remission after frontline therapy, the field's moving more towards cellular therapies, CAR T cells, due to the limited activity of auto in that space. So.